I'm a paediatric gastroenterologist. Actually, I'm a bit of a rare breed. You'll know there are lots of gastroenterologists. Some of you will have care here. Some of you will have care in other hospitals. And there's always a gastroenterologist in each hospital. There's maybe 3 or 4. There's about 10 paediatric gastroenterologists around London. I'm one of 3 that service North and West London. So a relatively rare breed. Doesn't make us any more special. The special bit of the patients. And I'm going to take you through a little journey. It only take us 10 minutes. And we have a disco whilst we're doing it. This hospital is unique for being obsessed about your bottom. And because of that, we've been able to offer paediatric gastroenterology services for about 10 years. And we know we offer very high standards of care. We get an interface with adult gastroenterologists, which puts us in a very strong position than some of the children's hospitals like Great Ormond Street that don't manage to access the adult services. So we can access surgeons, physicians who have expertise which is beyond that of paediatricians. So for the next 15 minutes, I'm going to talk about why children and adolescents are so special, what treatments there are, and what extra care we offer our children. But this applies a bit to the adults. You can earwig and listen in, and I'll explain why. You see, children are different. There is no doubt that if you get diagnosed under the age of 16, in other words, by a paediatric gastroenterologist, your disease is going to be a bit harder to treat. We don't see a little whiff of disease. We see quite a lot of disease in children. It requires a little bit more handling. You're more likely to go on to medicines earlier. We don't like to give you steroids because steroids are right as an adult, but as a child, their implications for health are not so good. They're not so good for your bones. They're not so good for your growth. So actually, we have to utilize other newer therapies earlier in children than we would in an adult. And perhaps the second one from the bottom is the most important issue. What separates me from all the brilliant people you heard this morning is I also have to make you grow. I cannot use medicines that stop you growing like steroids, and I can't really leave your disease just grumbling along, because if it grumbles along, it'll abort your growth. So I have to aim for very high standards of treatment care. I've got to get the lining of your bowel to heal, and I've got to get you to grow, and that may mean you might need surgery a bit earlier. Now, the reason why it's relevant to everyone in this room is because if you look at who gets inflammatory bowel disease, 1/3 of all of the patients, whether you've got UC or Crohn's, would have had it diagnosed in that yellow area somewhere between the age of 12 and 16. That's the commonest age group. But I will go all the way down to 1-year-old. I've got a 1-year-old child who's got equivalent of Crohn's disease, and the frequency you can see goes all the way up to adolescence, and then it peaks. So many of you who are patients will have had symptoms perhaps into adolescence. So it's very relevant what I'm about to talk about. We also know it's a bit more common. So when I started in paediatric gastroenterology, and I'm still very young, when I started, it was just coming on board, Crohn's disease in childhood. It's now a major force in paediatric gastroenterology, and it keeps me busy much of the time. And if you have a family relative, you've increased your risk of having inflammatory bowel disease by 5-fold. That works both ways. So you may have a child who you might wonder if they have inflammatory bowel disease, or you may be a child where you have an affected parent. That risk of 5 times more is quite substantial. So let me just paint you a picture. This would be a typical patient. There's quite a few of you in the room. You might get diagnosed early on the left side of here. You might get a little stumble through your course. You might have relapse. You might need some very special agents around about adolescence. And then you want to go to university. And if you're not fortunate, you might end up with a bit of surgery later on. And my job is to steer you through all of these, obsess that you have absolutely no symptoms. So my aim is that your symptom score is right at the bottom. But patients have traditionally had a very bumpy course. Throw in a few conflicting issues. I've got your GCSEs. I've got to get you to grow. You're bound to want to find a partner. You'll want to smoke with your partner. You'll want to go to university and then have a different partner. And I have to put all of that into the story to manage your Crohn's or your colitis, which makes it a little bit more sporty. But the reason I do this job is because as a group of patients, you are privileged privileged to care for. You're a specific group of children and adolescents who, if we get it right and we do the journey together, we have very good outcomes. So my job is to make you grow. I don't look at blood tests. I'm not that fussed about blood tests. I mainly look at whether you put on weight on a growth chart or you put on height. And I have an endocrinologist, a hormone doctor that works with me in the clinic across the room to make you grow. My job, if you had to sum it up in one sentence, apart from keeping you continent, my job is to get you to your final height. That your end height is what it was meant to be before you got your inflammation in the bowel. So the first thing I want to show to you is that we all have to make your disease go away. I have to really make sure your disease is absolutely resolved. Because if you have a grumble in your disease, it might affect your grow. I have to make you grow, and I have to fit around your life events. So what tools do I have? Well, these are the treatment tools, but actually they're not really the tools. The tools are your parents, your education, Marion and the team, the adult gastroenterologists, the surgeons, nutrition, dietitians. And we will employ any of these tools you see sat up there. But these are just the treatments. The tools are the wider team that you've seen, and that includes you, your motivation, and that of your parents. One of the main ways we treat and try and get healing of your gut is not worry about steroids, but use a process of enteral nutrition. Enteral nutrition is where we will change the contents of your gut to try and provide healing of your bowel. This is a really common pediatric perspective, and adults are a bit negative about it, which is why you end up a bit more on steroids. This can get your Crohn's into remission or to turn your Crohn's off in 90% of patients. It's a great route. Slightly underutilized, but it just shows you an example that we would use for your dreadful Crohn's. You can see a picture of the dreadful Crohn's at the bottom. We'd use nutrition in preference to treatment. So again, I stress to you that the tools are not all about medicines and treatment. The tools may include a dietitian, they may include ways of getting the feed into you, they may include surgeons. But at the end of the day, most of you who are under my care will have at least touched on two or three of these mechanisms. But these are delivered by a wider team, and if we get it right, which actually invariably we get very close to getting it right, then you'll get better. So conclusion here, the message I want you to take away is early use of nutrition. Love your dietitian. We'll use treatment options early, so we won't leave you with a little bit of disease. We want to obviate your disease, get rid of it, which is why many of my patients have had lots of endoscopies. We won't just rely on you saying, well, you know, I feel a bit better. No, we want you 100% better. And if I can't be sure you're there, you'll get another endoscopy. And as a consequence, you're likely to start some of the heavier medicines earlier so that you grow. So the last few minutes is about you, is about adolescence, about you as parents and your children, and what is special about the tools and the team that we would use to get you better. Well, we're blessed, as I say, at St Mark's because I can interface with what I as a paediatrician, judge to be certainly the best gastroenterology service that you'll get probably in the UK. And I can say that without prejudice because I haven't been a consultant just here. I've been a consultant in other continents and other hemispheres. And I'm very confident that this is the right place to put adolescents. If you are an adolescent, you want what's on the left. This is what I'm told. You want to be normal. You don't want to have endoscopies and bowel prep because you'll hate it. You don't want to have blood tests. You don't want to come to hospital. You want to be well, and you want to have smoke and have sex, or both at the same time. That's what adolescents tell me. I don't know. I want what's on the right. I want to know your gut is completely healed. I want to keep scoping you the whole time. I want you to see me every week. I want to use all my tools and medicines. I've got lots of friends I want to introduce you to. I also don't want you to smoke, and I don't want you to be pregnant. And those are my aims, and you can see that they conflict slightly. So we compromise, and we run a very good partnership. But then in that partnership, I have to throw in the third member. Sometimes the third, fourth, fifth, grandparents, cousins, everyone who turns up. Because parents and you as parents will have a different perspective. You want cure, you want to know about your disease, which is why you're here. You want your children to have 100% quality of life. You might compromise as an adult and say, do you know what, I can't go to work today, or I might have to have a stoma bag, but as a parent you will not tolerate that for your child. And it is not uncommon for me to hear parents say, if only it was me that had the disease and not my child. Some parents have guilt because they themselves may have inflammatory bowel disease, they're worried about the siblings, and they're worried about career choice. So this is what we do to tackle it. We run a program. All of my clinics are paediatric and adolescent based. So the moment you come to me, I'll be tackling these. To specifically tackle some of these issues, we effectively run a young person's clinic. We call it a transition clinic, but really it's a young person's clinic where I'll show you a wider team. There's a slight change in ethos where you take a bit more responsibility for your disease. You would kick your parents out. We often introduce you to new doctors. You'll learn to have your endoscopies without an anaesthetic, so it's a really easy procedure to have done. We might have to introduce you to less nutrition than you had before. But the outcome is that in that green area where we work into adolescence, we are confident that you as parents and patients, that your scores won't yo-yo up and down, and we will keep you with very low amount of symptoms to get you through all of these stages. We know we offer a sensible service. Our patients tell us we offer a good service. We attract referrals from throughout the M25 and beyond. You're very welcome to access me. Most of you who know paediatrics here will know you just turn up in clinic almost whenever you need to. We're very interested in getting your colitis right. This is your journey, and we wish to be part of it. And that's paediatrics for you. So those are my final conclusions. You are special because your medical and growth needs are critical to me. You do need special handling. This organisation is set up for you, will take you from infancy through as a young adult and beyond, although I'm not very interested in what happens really beyond. And we're obsessed about your bottom. So I'll stop there. Thank you.